Welcome to Healthcare Authority's Medicaid Suspension Module 3, Coordination of Care. The topics for this training include background information, coordination of care definition, coordination of care life cycle, coordination of care models, looking forward, and resources. Background. Medicaid suspension was the result of the passing of Substitute Senate Bill 6430 to direct Healthcare Authority and the Department of Social and Health Services to raise awareness of best clinical practices to engage individuals with behavioral health disorders and other chronic conditions during periods of incarceration. With the help of stakeholders, Healthcare Authority was able to meet the requirements to list some best practices on behavioral health and care coordination, funding opportunities, and list of training and resources. Healthcare Authority created a work group, and the subject matter experts who participated represented some of the managed care plans, Behavioral Health Organization, Department of Correction, Washington Association of Sheriffs and Police Chiefs, Healthcare Authority and Department of Social and Health Services subject matter experts, and Association of Counties. As a reminder, beginning July of 2017, individuals who are incarcerated or in an inpatient hospitalization over 24 hours have their full scope Medicaid coverage changed to limited. Upon release, their limited coverage is then changed back to full scope coverage. This process is done without the need for action by the individual, and this change is done in an overnight process. The goal of the Senate Bill 6430 is to provide continuity of care for recipients of Apple Health during periods of incarceration or commitments in a state hospital by suspending, not terminating existing coverage, applying for healthcare coverage in suspended status, and identifying and communicating behavioral health best practices to promote a smooth transition into the community. Coordination of care definition. Care coordination is an individual's healthcare needs are coordinated with the assistance of a care coordinator. The care coordinator provides information to the individual and the individual's caregivers. They work with the individual to make sure that he/she receives the most appropriate treatment while ensuring that healthcare is not duplicated. A care coordinator can be anyone who is an allied healthcare staff, such as community health care workers or certified peer counselors, and others to facilitate the work of the care coordinator or to provide services to enrollees who need assistance in accessing services but not care coordination services. Coordination of care life cycle. This life cycle is patient-centered. It starts with the assessment at top by a managed care entity or a behavioral health organization. A care coordinator can be assigned after diagnosis or during the treatment plan, including various treatment and follow-ups. A care coordinator's goal is to have constant engagement, keeping the individual updated about their care and next steps. Coordination of care models. Listed here are examples of coordination of care models that can include the following: patient-centered medical home, health homes, Coleman model also known as care transitions, peer bridgers program, community health workers, the Pathways Hub model, and targeted case management. Patient-centered medical home, PCMH, is a care model that involves the coordination of care individuals' overall health care needs and where patients are actively involved in their health care. The following are components of a PCMH care delivery system. That is, comprehensive care, where medical home practices bring together provider teams to meet the needs of their patients, and patient-centered, where a whole-person care that reflects the needs, preferences, and goals of patients and families. In continuation to patient-centered medical homes, they may provide coordinated care, accessible services, quality and safety, and for more information, please visit the link listed on this slide. Health homes is another model that the Department of Social and Health Services, along with the Healthcare Authority, have collaborated with federal partners since 2013. Health homes have received strong support from individuals, local healthcare providers, and advocates. The program can help clients in developing a person-centered health action plan, improve self-management of chronic conditions, and ensure care coordination and care transitions. Some of the programs health homes programs may provide are comprehensive care management, coordination of care, health promotion, comprehensive transitional care, individual and family support, and referral to community and social support services. For more information about this model, please visit the webpage listed on this slide. The Coleman model, also known as care transitions, facilitates new behaviors, skills, and communication strategies for patients and families. This model increases self-management skills and provides continuity across the transition, assigning a care coordination coach who engages the patient. It teaches individuals medication management skills and encourages them to be self-aware of their care needs and to ask more questions regarding their care. For more information, please click on the link listed here. The Coleman model can include assisting patients and families with communication skills and teach new behaviors to manage their recovery, increase self-management skills, and provide continuity of care across transitions, teach individuals medication management skills and encourages them to be self-aware of their needs and to ask more questions regarding their health. This can also include meeting with a transitions coach in the hospital or jail to discuss concerns and to engage the patients and their families. Also continuing meeting with the transitions coach in the home for follow-up visits and accompanying phone calls designed to increase self-management skills, personal goal attainment, and provide continuity across transition. The Peer Bridgers program is currently being used in King County for psychiatric-related releases. The Peer Bridgers program uses certified peer support specialists. Bridgers are fully integrated within the clinical interdisciplinary teams. Services are customized according to the individual's needs, and this is currently being used in King County for psychiatric-related releases. For more information, visit the King County Peer Bridger program listed here. Community health workers are dedicated individuals who have relationships with patients. They serve as liaisons between health, social services, and the community to facilitate access to services and improve the quality and cultural competence of service delivery. They are able to advocate for needs and perspectives of community members served, provide cultural link between organizations and communities, help individuals get access to health and social services they need through case study, referral, and follow-up, and community members increase health knowledge and become self-sufficient. Community health workers are frontline public health workers who apply their unique understanding of the experience, language, and cultural of a particular population. They work in a variety of health and social service roles to connect individuals to community resources, outreach work, and provide peer counseling, health education, case management, or other similar tasks. For more information, visit the link listed on this slide. Here is an example of a community worker approach in Ferry County.
80% of people who are in county jails have either a substance abuse or mental health issue, and oftentimes it's co-occurring. When we talk about health reform and population health, we will never get there if we can't get a more systematic and organized effort. But it's a very significant part of the population that has these untreated issues.
Ferry County is unique. You gotta understand we're a small community. We're slightly different, so it makes it hard for people to find jobs. It makes it hard for people to support their families. And when you can't find that, the anxiety and the stress from that can lead to a lot of bad things.
They don't have jobs, they don't have the ability to manage their medication. And that's a big deal for a couple of reasons. One, it's really costly for counties to restabilize somebody's health, and it's really expensive to keep somebody in jail.
Once an inmate's in jail, they have no insurance. Nothing, nada, taken away. A lot of those prisoners or inmates, they have families. And so those families are affected when they're in jail too.
You work in corrections long enough and you start to see the same people over and over again. It's getting to the point where I'm not just seeing the same people, I'm seeing the same families. I've had grandpa, I've had dad, now I'm having son. And it's a generational thing.
The family structure breaks apart, and so if there's anything that we can do to keep that together, that would be a plus.
The county foots a ton of medical bills every single year, and a majority of those come from the same people that I will see 4 or 5 times. The major factor is instability.
The accountable community of health really moves this from just a feel-good, it's the right thing to do, to a business case for why we need to make the changes we need to make, the collaboration that's going to be necessary, and the ultimate goal of improving community health. Our Accountable Community of Health regional project is the Pathways Hub model for a jail transition population.
The hub coordinator will coordinate with all the resources that they need, housing assistance, medical, mental health.
Making sure they have a primary care doctor so they can keep taking their medication or continue the treatment that they've started.
It'll save money for the county in the long run, save money for the taxpayers, and it'll benefit the whole community.
And eventually, by stabilizing them and getting them into a stronger position, then they can start take the lead on their own and get to their own appointments and get to their own things. And then they transition out and somebody else transitions in. And hopefully you do that with enough people, you make a big enough difference.
When we think about our work, it is in the broadest sense of community health and improving the systems and the processes and the services that make each of us healthy.
Maybe eventually at some point, the system works like it was supposed to be designed for. You come to jail once, you decide you don't like it, you don't come back because you'll have that resource available to help prevent it.
It actually touches people's lives and helps improve their family life.
It's a chance to try to do something to change things for the better. And if it works, maybe that's just the first step and we can keep doing more.
The final care coordination model for reentry into the community is targeted case management. This refers to case management for specific Medicaid beneficiary groups or for individuals who reside in state-designated geographic areas. Providers are recognizing that a one-size-fits-all case management solution is outdated. Case managers are starting to think in terms of solutions that are specific to the needs of the individual they are serving. For more information, visit the link listed on this slide. If you are thinking about starting up a care coordination model, some of the things you may want to think about is define the care coordination model and define core principles to be shared across the health system. Provide coordination of medical and non-medical services. Focus on improving transitions between care settings and tailor case management to those most at need. Keep in mind this should be patient-centered and consumer-friendly. It may require hiring specialized staff, and also consider regular health screening assessments and non-medical service such as housing or food assistance. The focus should be on transitions between care settings and use of electronic health records. For more information, click on the link that says Healthcare Solutions. Looking forward. Some suggestions we have for those who have limited resources are to consider a pilot or project to engage at-risk inmates. Start small. Prioritize your most needy population. Connect with a managed care organization in your local area. Engage providers and other community agencies who may have the same interest in care coordination. And contact the Healthcare Authority Medicaid Suspension team if you need assistance. A few recommendations that jails can do as part of the care coordination process is to gather health information at booking. Completion of an observation form is encouraged for handoff at booking and mental health screening at intake. In-facility treatment for substance use disorders. Jail pre-release planning for seriously mentally ill. Use of long-acting injectable psychotropics, and Medicaid screening and enrollment at booking. In continuation to some of the recommendations, training for individuals on how to use primary care behavioral health services in place of emergency services and RX compliance, use of assisted outpatient treatment and medication-assisted treatment. Recommend entering into a business associate agreement for information sharing purposes, and be responsive to jail's requests for inquiries on coordination of care. Resources. For more information, click on Healthcare Authority's Training and Education Resources. For information on how you can become a volunteer assister, please click on the second bullet. And if you want more information about Medicaid suspension, please visit our Medicaid suspension webpage listed on the third bullet. And for more information about the Healthier Washington project, visit the link here. If you have questions, please email us at medicaidsuspension@hca.wa.gov, or for more information on Medicaid suspension, click on our webpage listed on this slide. Thank you for joining the Module 3 Medicaid Suspension on Coordination of Care.